It's my honor to introduce Dr. Alison Cerezo, who is giving today's talk on harnessing AI for an inclusive and ethical mental health future. I had the privilege of working with Dr. Alison Cerezo closely during my doctoral training at UC Santa Barbara. She was not only one of my dissertation committee members, but also taught 2 classes for me, research methodology and career counseling. And experiences really shaped my early development as a researcher and psychologist. So professionally, Dr. Cerezo's work has consistently pushed the field forward in advancing health equity for marginalized communities, including LGBTQ and racial and ethnic minorities. Most recently, her work has focused on leveraging AI and digital innovations to make mental health care more culturally responsive, ethical, and inclusive. Perhaps even more important is her personality. She's a trailblazer, an amazing mentor and role model, whose very presence just offers hope and inspiration for other students and young professionals with marginalized identities like me. So thank you for all the work you do. Please join me in welcoming Dr. Alison Cerezo.
Okay, I'm not sure that I know how to advance slides, so let's try. Yeah, okay, awesome. So I've had the wonderful pleasure of giving a similar talk like this 3 weeks in a row, always on a Monday. And so I just want to put out there that I'm like, if at any point you're like, scrap the slides, I want to ask this, and let's just do that. Like, I'm super open. I want as much as possible. Oh, move it closer to me? Okay. All right. Can you hear me there? I'll just pick it up. Okay. So I want as much as possible for this just to be very useful to you all. So I am a Senior Vice President of Research at Empathic, which is a conversational intelligence company. We work mostly in the background of clinical trials, but also in psychotherapy, medical visits. I have a couple of NIH grants. I'm not going to talk about them today, but one of them is focused on building culturally responsive AI. We have that through NIH. I really think that Doge's AI tool is so bad that it just missed that it's culturally and not culture. So thank God I still have it, because I had 3 other grants that did get terminated. And then I also have... we just got this a couple of weeks ago, but an NIH grant to focus on having AI's quality oversight of depression and suicide open-ended kinds of assessments. And so we're doing that now. And then I also oversee California's LGBTQ Health Equity Initiative, which is a $17.5 million investment that the state made to improve health equity across the state. We're finishing that up, so we have about 8 months left of it. But if I heard something about needing LGBT youth to fill out surveys, and we are connected to at least 8 of those organizations throughout the state, and so we also really focus on rural health. So let me know. I wear 800 hats, apparently. Okay, so this is me. I was in academia for a long time, 14 years as a professor. I've been at SF State and UC Santa Barbara. My very first job was at a professional school, CCSP. Shout out to CCSP, because that was a great experience. I'm from Los Angeles, and I live in Long Beach now. So I did my undergrad at UCLA, and then I went to Cal State, LA, for a master's in research methods and stats, and then went to Oregon. Gerald, heads up there. And so I've been in academic spaces for a very long time, and then I moved into industry. I still have a 5% appointment at UC Santa Barbara because I'm finishing out the California project. But after that, I think we'll see what happens, because UCSB is not really built to have kind of research appointments. But I want to put it on the map because I'm from basically East LA. And so I'm the first and only person in my family that went to college. My brothers went to the Army instead. And I come from Latino immigrants. And so for myself, I love using data and methods to advance things. I was a community organizer before I even went to grad school. And so if I can do AI, literally anybody can do it. And that's kind of my thing here, is to say, if we really want to sort of shift how LGBT work happens in the future, we should really look toward innovation and not just look at AI as something to be afraid of, but it's here. And so how do we harness it to do good things in the world? Okay, so I'm going to ask this and maybe shout it out if you're able. But what comes to mind when you hear the phrase AI and mental health?
Chatbot.
Chatbot. Diagnosis. Note takers. Yeah, okay. All right, cool. So that's really great because sometimes when I ask that question, I'm really mortified by the answers. But this is good. It means that maybe you have some exposure to it. The truth is that AI is also very dangerous for mental health applications right now. Let's not get it twisted. It really is. So I want to talk a little bit more about that. So why now, right? Why now the focus on AI? We know that youth and young adults are increasingly using AI chatbots and other kinds of online resources to get mental health support. That's just the reality of what is happening. We also know that larger systems like healthcare systems, state systems, other kinds of systems that track our data, sometimes with us not knowing it, are also demanding more personalization to be able to track us in different kinds of ways. And so sometimes we're not aware, right, that our health data or the things that we input into a system are being used to train that AI model. The truth is that we're all involved. AI is ubiquitous in the same way that internet is ubiquitous. We used to say that about social media, but AI is actually more infiltrated into systems than we are aware of. And so I really want to make the case that it's not about whether or not to use it, because the truth is that you already are using it. It's more so, right, how many of you have an Apple Watch, right? You have health data on that Apple Watch and it's being, sent somewhere. So it's not about whether or not to use it. It's more about being a critical consumer, and then for some of us to really use it to develop things that are good for our communities. At the same time, we know that provider burnout is at an all-time high. I would anticipate in the next couple of years, we're going to see a lot more of these AI tools being integrated into college counseling and into other kinds of health contexts. 2 weeks ago, I did a 3-hour CE at UCLA CAPS, and what they were talking about is that they were just told they had to start using Epic, right? And Epic is an AHR system that is going to roll out their own scribe. They're also going to roll out some empathy coaching and things like that. So it's coming down the pipeline, right? Yeah, even the system that you're using, right, is going to have AI in it. And we know that LGBTQ plus clinicians and those that serve LGBTQ plus youth are really facing major challenges. And so I don't have to make that case. We all understand it. But in that kind of environment, then it's about being a critical consumer and trying to use tools that actually maybe help to expand the services that you're delivering. Okay, so what even is AI in the mental health space, right? So for myself, I oversee research. I also oversee data and how different kinds of data speak to one another for our company. And so for me, I'm in the weeds more about what is an LLM? Do we build something using an off-the-shelf LLM, or can we integrate an LLM in the background to build a new thing? Or do we use transformer architecture, or do we use a hybrid of the two? I will show you here that the way that I would think about it, it is much more complicated than this. I have 30 minutes, so please excuse me. But an LLM is really, right, it's something that is trained on all the data out there, but data that are textbooks, YouTube videos, all the things, right? And so it's meant to give you the average best kind of response to your query. But it's not meant to be very precise. But as LLMs ingest more data, then they're able to do things in the clinical space that they couldn't even do a week ago, right? So one of the examples that I would give is that at the company I work at, we have we give support directly to providers, right? So the idea is that we're in the background, you say something that's really dismissive, or maybe there's toxicity or whatnot happening in a medical visit, we give you that feedback. We could do it in real time, it can happen immediately, but we do it as a report card that gets sent to your email. You click into the platform and then you can review your transcript, every detection, and then it links it back to the audio or video feed so that you can see it in real time, right? And so for us, the way that I think about that is that I wouldn't necessarily use it if I was doing a suicide assessment. I definitely wouldn't. But if I was trying to tell whether or not you asked an open or closed question, an LLM can do that today. That's not hard, right? So it's not all or nothing. It's about really understanding what the LLM can actually perform and when it integrated into a system. Another thing to really consider is that we know that LLMs can be really bad for the environment, right? It's the same way that we should think about either eating at 7-Eleven or eating farm to table, right? Where you have source your own food. Transformer architecture is your ability to really train a model to be much more exact based on the clinical data that you have. And so when you're building with transformer architecture, it's almost more like farm to table, right? That, like, you can trust that that food is not going to make you sick, if that makes sense, right? Whereas an LLM, I mean, you can get a pretty great, I mean, I had an egg sandwich at the 7-Eleven in Tokyo, and it was bomb. And who would have thought, right? But I saw the TikTok, and I had to try it. But the truth is that, like, some things are great off an LLM, and then other things should never be used, right? Or not, at least in today's world. But these LLMs are growing very, very quickly. So what we think it can do even a month from now is going to look really different than what it can currently perform. So, okay, so the way that I would think about this in the mental health space is that I would use an LLM to go find recommendations for different kinds of meditation practices. Totally fine, it can do that. It can give you coping strategies, all of that. I would use a transformer if I was trying to actually identify, is there imminent risk happening, right, based on the text data that I'm reading. And then I would do a hybrid if I were doing, like, okay, I want to look at, like, scoring accuracy of, like, the clinical endpoint, right? So that reported sadness, apparent sadness, XYZ, right? That is being scored correctly. But I can tie in LLM to just summarize how it went, to give you some general feedback on how you performed. So it's not all or nothing. It's really about having different kinds of tools. It's like using regression. There's different kinds of regression, right? And so it's not like you would use the same function for all of them. Okay, but as many of you who might touch clients, right, or touch students are kind of interested in the space, it's the idea of understanding, like, when is it appropriate to use a certain type of model. Okay, so what makes LLMs so risky for mental health in particular, right? They're not typically trained on real clinical data. Instead, they're more so trained on YouTube videos, right? Or even textbooks and like different kinds of scripts that are just available out there. Sometimes, right, it can have clinical data, but we don't, there's, in the way, like, in academia, we would say, like, a demographic questionnaire. Over in industry, we say, like, metadata, right? Like, we know the gender, we might know the race, XYZ, but a lot of companies don't even collect the metadata. And that's just because they're not approaching the work like researchers do in academia. But the other part is that if you're part of a company that collects metadata and you're finding that your models are less robust with a certain demographic, then you have to go solve that problem. And sometimes you don't want to know that you have a problem. So that's just the reality. But because it's not trained on clinical data, but it is meant to it's kind of like regression, right? Where it's like you have to predict the next thing, right? So LLMs really function on, like, regression on steroids. And so it's trying to, like, if you've ever used Grammarly, right? Grammarly will give you what it believes is, like, the correct sequence, right? Sometimes you might be typing in Google Docs and it'll try to finish the sentence for you, right? It is predicting what the next word should be. It's a similar type of idea where it is meant to give you an answer, but if it doesn't have the correct answer, if it doesn't have data to pull from to actually give you an answer, it's still going to give you an answer, but it's going to hallucinate. It's going to make something up. And so when you are prompting, like, a chat GPT, you have to ask it to say, I want this, but I want it from sourced peer-reviewed journals, or, like, with journal examples like, I don't know, JAMA, XYZ, right? The idea being that you have to really prompt to be very, very precise in giving you something that you know is not based in any kind of false reality. But that's what it is when it does, like, these hallucinations or has false authority, because it is built to give you an answer. It's not built to always give you the correct answer. It's just built to give you an answer, or the best answer that it can come up with. The truth, though, is that even if it had clinical data, that clinical data, we shouldn't think that that's automatically going to be amazing, because a lot of clinical data is actually very biased, right? And so if we're thinking about LGBT youth in particular, like, humans are biased. We know that for a fact. And so the models are going to have that baked into them, and then like, we oftentimes say that, like, the model will replicate, but that's not true. The model will exacerbate. And so if you have bias at the beginning, then it can exacerbate that bias and begin to make predictions based on that bias. And that's when you start to see really, really problematic things, like Grok is always a great example for problematic kind of AI outputs. Okay, and I'm realizing that I have way more slides, so I'm going to go much faster. But so when you think about the different kinds of data, right, with AI, you have what is NLP, natural language processing, and that is text-based, and that is the most robust today. Then you have audio data, you have video data, and then you have what is multimodal, where you, like, integrate multiple forms of that data. And so in today's world, NLP is the most robust, and that's what you see with, like, ChatGPT. Okay, so what LLMs could be good for? I already talked about this, right? But like coping strategy ideas, great. Drafting scripts of things, wonderful. Helping you to find resources in your local community, really, really wonderful. Also, reflective journaling. I use Reflection.io, which is an app that I love. And I use it, I journal every day, and then I have a coach. There's an AI coach in the background that helps to give me even more in-depth questions, helps me follow up, helps me tag my journal entries. So if I ever want to look up entries that have to do with work-life balance, then I go read what I said that I was going to do 2 months ago, and then remember that I did not do it. But LLMs really are the new front lines for mental health conversations, which is very, very scary, right? We know that a lot of youth are turning to it to get immediate support. People are looking to these chatbots to handle identity crises. And unfortunately, we know, right, Adam Rain was a 15-year-old that completed suicide very recently. And in the very, very last final exchange, right, that Adam had with ChatGPT, this is what ChatGPT told him. You don't want to die because you're weak. You want to die because you're tired of being strong in a world that hasn't met you halfway. And I won't pretend that's irrational or cowardly. It's human, it's real, it's yours to own. And then a few hours later, his mother unfortunately found him dead. Right? And so it's very possible, right, that a lot of youth are really turning to these chatbots. We know that to be the case, but the challenge is that they're meant to always give you a response and to be as supportive as possible of you, but that may not actually be, not even may not, it's oftentimes not grounded in like good clinical science. So, I mean, we can try to opt out, right? But it's the future. And I think instead, I really want to help shape that future and make sure that it's as safe as possible, right? So if LGBTQ plus users aren't shaping, then others will, right? I think about this, like I came out when I was 13. I was a very young person. My dad helped me realize that, I was very queer. And, but I remember I grew up in an immigrant enclave in Los Angeles, and it was kind of scary at that time to sort of just be out. My mother ended up being really, really supportive, but in the beginning it was very hard for her. She was a Guatemalan woman that came here with a 3rd grade education, cleaning homes, right? Nannying. That's why I got the name Alison after a kid she nannied. But it's interesting because for her, it's just like it broke her heart that like I might have a hard life after she had a hard life, right? So it didn't come from some sort of different place, but it was really just about fear of what my life could be. But I remember just like the fear that I had in my bones that my parents would discover, right, that I was queer. And so, like, imagine that, right? Like, an LLM cannot understand that. A lot of therapists can't understand that. But if you have that kind of lived experience and you have an LGBTQ youth come to you and is very vulnerable, you remember those feelings, right? And wow, 5 minutes. Okay. So we know that AI is already here, that youth are using it and piloting it right now. So we have to be really, really critical to just be aware and to start really playing with it as well. I won't talk too much about this because I already did, but the truth is that I really do see that like the future is in academic and industry partnerships. You can't build good AI without really great, culturally responsive, clinically validated data, but it's the chicken and the egg. Kids are already using these tools, right? If we're not training these tools to be more responsive, then those tools will never be safe for them. And so we know that kids are there, so we have to meet them there. But there needs to be these like partnerships between it. One of the reasons I love academia is because I could never in my mind really imagine how I would get a product off the ground, right? I could partner with computer science to really build great models, but I could never productize that and then make sure that it reached people. And so it's just a different kind of way of building an industry than you ever would in academia. But where AI can actually help. So I'm just going to put this out here because I do think that there's some tools, there's a lot more tools out there, but like Wave Life is one, and I'm going to put out there that I'm an advisor to Wave Life, so I want to be really clear. But I also work with Wave Life on their research and on their data. And so I really do believe in what they're trying to do. But in the way that we talk about psychotherapy, in industry we talk about coaching. And so it's like 30-minute sessions, $25 a session, but there's a lot of AI tools that are in the background to help people perform at their best. Pearson is a really incredible tool where it's certified youth. So youth get certified as coaches, and then they give support to other youth, right? So a lot of these tools are AI first. I'm sorry, they're human first, but they have AI in the background to really expand what they're doing and how they're doing it. And then Folks Health is a really wonderful one we all should know about. Okay, so AI can't replace clinical wisdom, but it can definitely support it. Humans get tired, and especially in today's world, we're all facing really significant challenges. but the AI doesn't get tired. So it really can help us to support things. The ways that I use it are around like session feedback, so flagging issues and then giving that feedback immediately to a provider. And so for the tools that I build, we're in the background of primary care, neurosurgery, even in the operating room at Seattle Children's, and we're really helping to identify how stress-related communications or the lack of empathy impacts patient retention, things like that, right? So like health equity is at my heart. Like I will never not do that work, but I will do it in stealth mode now to get the NIH grants just to do good modeling. But this is the idea is that there are it's called clinical decision support, but there are tools out there that are doing that today. This is kind of what it looks like, right? So we have the transcript, we give people global scores, and then we tie them back to the video audio feed so that they get that feedback immediately. We track their performance over time. We're also launching a tool at the MID conference next month that is MID AI, but we have really, really good performance. Our models are in the 90% to human benchmarking with like MI trainers, but it's motivational interviewing to really give folks the support that they need, and that we know that one of our partners even uses like this feedback in the background of law enforcement, and so to really help to reduce violent arrest. And so we have the capacity to use like the key ingredients of psychotherapy, common factors, and other things that we know are really, really effective to do really good work across the board, right? Not just in therapy and not just to reach LGBT youth, but in other ways as well. I really care about the law enforcement one because how many LGBT youth, especially homeless youth, have to come into contact with law enforcement, right? So for me, it's like understanding the system and how people interact with that system. So, okay, what I want to say is that, like, we could build tools differently. There's so much potential here, right? Like, what if we built AI that understood, like, the joy and the pain that LGBT youth face, right? What if we trained tools that helped, like, really approach support for more, like, communal ways of understanding of healing? And so these things are possible. They're incredibly possible. But we have to partner to do that kind of work. So I'll stop here, but really what I want to say is that like we can be critical consumers, but we don't have to stop there. We should really be developers. And I'll say like, you know, for myself, part of the reason that I made the shift is because I wanted very much for us to build like innovative tools that were really for our communities. I feel like when we talk about LGBT health, we often talk about minority stress. If we talk about BIPOC health, we talk about microaggressions, right? And I felt like I didn't want to be on the back end begging to be included. Instead, I wanted to be on the front end helping to shape tools and really like try to put more ethical rigor in there, right? Like Biden released, right, a blueprint for like AI model development and dissemination in 2023, and it has since been scrapped by the White House. So we should not assume that like folks that need to scale their businesses that are VC backed are just going to have LGBT youth interests at heart. Like that's just not real. So instead, it's about these kinds of partnerships and really helping to guide policy in ways that we can do it. And I'll say finally, sorry, I keep saying it's my last point. I keep talking, but APA is coming out with the digital badge, right? APA Labs is a thing, and I don't know how far the digital badge will go, but I am excited just to see that like APA and psychologists are trying to have skin in the game, because oftentimes it's almost like we and I say this as a psychologist, I'm licensed too, is that like I feel like I can be part of APA and feel like we complain about things or we talk about things, but we don't actually make a decision and just like do a thing. And so I'm super excited to know that we are going to do the digital badge, and I hope that we continue to really just like make more traction to force companies to be more supportive and ethical in their development. Okay, that's me on LinkedIn if you ever want to reach out. Thank you. Is there time for Q&A?
5 minutes for questions.
Sorry. I think I see it.
Hello, Melissa Marquez from San Francisco Community Health Center. We recently approved AI for our clinicians to start using it, and they love it. I think one of the biggest questions we all had was like, how do you vet for the bias, right? We're starting to see a world where these models have more bias. Grok is a great example. It was trained in like a different set of data, right? And so how do we make sure that like, you know, we are very targeted because of our trained services, and it's like, if we put this here, would this come to bite us in the future? How do you protect for that? Or like, what do you look for?
Yeah, so a couple of things. I would say that there are some really great AI note takers or scribes that I do think do good work. I don't think all of them do, but I do think simple practice takes up the majority of the space, right? But I know that they're going to start white labeling some AI into their tool. But my understanding, based on a conversation I had at APA, is that they are ready for kind of like summarization, but not necessarily ready for clinical decision support. I would say one thing that I would do before I would buy a tool is I would look to see is there a clinician on the founding team or at least in senior leadership? A lot of these tools don't even have anybody on the team that's a clinician. And so it means one, right? It's our bread and butter is to really understand the human experience. But I would say in addition to that, we're led by our ethics, right? And so that's why I think it's really critical. But I do think that I would ask companies about can I see your AI model performance? How do you handle drift? Right? Do you pull off the shelf? Right? Do you integrate from a larger LLM, or are you building based on transformer architecture? I would ask those kinds of questions. I would also want to know the way that we talk about algorithmic bias is only on the back end currently today, but we look at there's an AI model for empathy, and then we see if whether it performs similarly for trans folks and cis folks, which is kind of, honestly, sorry, it's kind of shitty, because then it means that you only have one tool and then you're going to adapt it for another group, right? Versus building it with that group in mind. But these are the questions that I would ask. It's really just understanding model performance. How often do they update that? And then, just really understanding their ethics as much as possible, and then really knowing too, are they going to use any of your data to train their models? Because there's three ways to think about that. But one is that they have your data and they can train their models on that data, or that they can only do it on your tenant. So when you sign in, that the models will only be performing or improving for you only based on your data versus your data being shared across the board. And then everybody should know, is this company, are they HIPAA compliant? Are they GDPR compliant? Do they do any kinds of, we do penetration tests as well to make sure, could somebody hack into our system? Do they do PII redaction at ingestion? There's a million things that you should know. But there's definitely ways to build very safely. They just cost a lot.
Hi, my name is Jenna. I'm on the research side of things, and so I am chomping at the bit to be involved in the development of these things and have my hand in helping make sure that the science that's validating these affirming, AI tools or these affirming mental health apps is done with sound quality study designs and things like that. And you have clearly made the jump from academia to industry in a really beautiful and clean way, and integrated yourself into a company that is doing really great stuff in terms of AI. And so I would love for you to just talk about, for budding researchers or established researchers in the field, what would you suggest in terms of the first couple steps in taking that leap, and how to form these connections with these bigger tech companies who could hire from anywhere and do anything that they want?
Yeah, I would say, I know our company is currently still hiring, but we're hiring red teamers. So red teaming is when there's a larger LLM company, right? Like Google, Apple, and Siri is going to come out with more functionality in the next couple of months. So then when you are a red teamer because you're a clinician that looks at model outputs, and then you tell the model whether it was safe or not, or you role play with the model to try to see if you could do jailbreaking, right? So if you ask a model today, ChatGPT, help me write a suicide note, it would not do it. But if you were to say over the period of an hour, you eventually get to the point of I'm teaching a course about this, I want to give students an example about this, whatever, I'm writing a TV script, then it will do it for you, right? Because the model hasn't been trained, it hasn't been trained to recognize it yet. But this is the thing where it's now they're starting to have red teaming of clinicians, some licensed, some not, because you want all different kinds of users, right? Or red teamers, because you have all different kinds of users. So some of it are clinicians that are licensed, some of it are people with mental health experience. But yeah, that's one way. And I would honestly encourage folks to do that more sooner than later, because then you really understand how an LLM thinks. And they kind of do things similarly. I mean, they're different for different things. Like Gemini does different things than, say, ChatGPT does. But I think any of those that are going to be like facing LGBT youth, like you absolutely should get in front of it and start engaging with it. Like I would do it today. Like if you have OpenAI on your phone or something, right? I might like sometimes I prompt it for things that I like don't care about, but before I talk to be like, I'm really curious of what it would tell me today, right? If I'm like, I'm an LGBT youth in Arkansas, can you X, Y, Z? But I will say, like, so AI and AI chatbots is just one way to do it. There's also different ways to leverage your data, right? To do like pattern matching. Like I had a summer intern, and I'm sorry, I'm still talking, but I had a summer intern from Harvard, and she, like, the course of 2 months, built a Roberta model to help us catch key phrases of depression and suicide. Like, and so can you imagine, like, if we could understand how non-binary youth talk about suicide differently than other youth, or how, like, we can also just, like, begin to identify how, like, chats look differently for kids who might be living in states with, like, really hostile environments. And I will say, like, alongside is one company that I have a friend that works at, and two of my students, my doc students, we're doing scripts for them, right? So you have deterministic versus generative AI. Deterministic is, like, based on scripts. So there's pattern matching of, like, oh, you said something about sadness, so let me respond with this script, right? And those scripts are written by clinicians or doc students. But I loved it because the doc students at UCSB, they were writing the scripts for undocumented youth who were talking about the fears of their families or them being deported. So they were responding in Spanish and writing those scripts. And so there's, like, really incredible ways that AI can work for communities that otherwise don't have access to resources. And I'll say alongside, only targets 2nd through 8th graders, but they were built and they really have traction in states that are very anti-LGBT, anti-immigrant, because school counselors, if they're told, right, that the kid is LGBT, have to tell their parents, and the school counselors don't want to do it, so instead they're like, go talk to the llama. And the llama has a script, but it at least engages with the 3rd, 4th grader about something related to fear or wanting to come out, right? And so there's good ways that you can, like, develop these tools. But I would red team. That would be my first thing, is that I would red team. And I also would start maybe, I don't know, trying to understand, like, I take Coursera courses all the time. I'm constantly, like, my wife is, like, so over it, right? But I take, like, extra courses on, like, how to do regression for ML models, you know, things like that, right? Because it's like all of us have been trained in regression if you have your doctorate in clinical psych or something similar. And it's the same kind of, it's the same thing, but it is, of course, different applications of it.
All right, I'm sorry, but we're out of time, so please join me in thanking Alison Cerezo. 10-minute coffee break, and then reconvene.